RBC and bleeding disorder. So we will talk about anemia. What is anemia? Anemia is a condition in which there is reduced circulating red cell mass in the body. That's the definition of the Robbins. But the definition that your teachers will ask you in Viva and will expect you to write in paper will be anemia refers to the reduced oxygen carrying capacity of the RBCs, leading to tissue hypoxia. How do we diagnose whether someone has anemia where their RBC is not able to carry enough oxygen? How do we know that? We look at two important factors to know whether a person is having anemia. First, hematocrit. Second, hemoglobin concentration of the blood. What is hematocrit? Hematocrit, it is a ratio of the packed red cell to total blood volume. Both methods are good, that is hematocrit and hemoglobin, for diagnosis, except when there are changes in plasma volume that is caused by fluid retention or dehydration. In case of pregnancy, there's increased plasma volume when person has anemia. That doesn't mean the RBC is not able to carry sufficient oxygen, or there's reduced production of RBCs or less oxygen intake. It just means that there is more fluid present in the plasma. This cannot be diagnosed with the two factors that we look for, that is hematocrit and hemoglobin, when there's changes in the fluid volume. So it's not the most accurate method to see whether the person has anemia or not. But in most cases, we diagnose anemia with help of hematocrit and hemoglobin. There are many ways to classify anemia. One way to classify anemia is according to alterations in RBC morphology. When we have to classify whether the person is anemic, we look at two ways. We look at RBC and we are like, okay, we can classify it on the basis of morphology, or we can classify on the basis of cause or etiology. So morphology, whether the RBCs are normocytic, normochromic, hypochromic, or normocytic, hyperchromic, whatever. We can look at the RBC's color, RBC's density, or the pallor is 1/3 pallor, more, less, and accordingly you can classify anemia. And etiology, as in maybe it's a problem in production of RBCs. Maybe enough RBCs are not being produced, so there's a problem in the bone marrow. So the reason, or increased destruction of RBCs, maybe the spleen is overactive and we have splenomegaly consuming all the RBCs. That can also be the cause of anemia. So there are two ways you can classify, is based on morphology and etiology. So one way is to include way we can include is by red cell RBC size. That is, we look at the pallor. We don't physically measure the RBC, is it big or small. We look at the pallor. That is, it could be normocytic, microcytic, or macrochromic. And accordingly, there's a degree of hemoglobinization reflected in the color of RBC. Is it normochromic or hypochromic? Reduced color or normal color? There's no hyperchromic. So according to size, it could be normocytic, microcytic, macrocytic, and according to the degree of hemoglobinization, it could be normochromic or hypochromic. There is one way to classify anemia. Microcytic hypochromic anemias are caused by microcytic, which means they are small. Hypochromic, not as concentrated with hemoglobin as they should be, are caused by disorders of hemoglobin synthesis. And macrocytic anemia are due to abnormalities that impair the maturation of erythroid precursor. So microcytic, hypochromic, they deal with disorders of hemoglobin synthesis. The problem is with the hemoglobin synthesis. So you will see the hemoglobin pathway. And macrocytic anemia are due to abnormalities that impair the maturation of erythroid precursor in bone marrow. So there you will look in the bone marrow and see what is the problem in the process of maturation. Now this chart is also given in Robbins. They classify anemia according to the etiology. See, causes of anemia could be blood loss, increased RBC destruction, which is also known as hemolysis, and decreased RBC production, red blood cell productions. And it is due to underlying mechanism. Now, acute blood loss and chronic blood loss are two ways. Acute blood loss and chronic blood loss are two ways we lose blood. Acute, immediate cause will be trauma, and chronic, this is GIT bleed, GIT lesion, gynecological disturbances. All this can come in long term because they're not immediately detected. Usually endoscopy is done in case of GIT lesions. Now, hemolysis or increased RBC destruction. There could be many ways this can occur. Hemolysis. 1. Inherited genetic defects. Now, inherited genetic defects, maybe the RBC is not able to maintain a proper shape. Why? Because it's defect in the membrane. Then it will be a case of either hereditary spherocytosis or hereditary elliptocytosis. The RBC will be appearing spherical and elliptical in shape respectively. There could be enzyme deficiencies. How? One enzyme, HMP shunt pathway. Hexose monophosphate shunt enzyme deficiency. Problem in that. Why? There could be T6PD deficiency, glutathione synthase deficiency in that pathway, leading to hemolysis. Glycolytic enzyme deficiency, pyruvate kinase deficiency, hexokinase deficiency. So these can be observed in glycolytic enzyme deficiencies respectively. Hemoglobin abnormalities. Hemoglobin abnormalities. Why will there be hemoglobin abnormalities? Because there will be deficient in globin synthesis, not sufficient globin. Alpha, this alpha chain, this beta chain, there is deficiency in production of either of those chain. So what we'll see thalassemia syndromes. And then there could be structural abnormality or hemoglobinopathies. Structurally there could be something wrong. Sickle cell disease or unstable hemoglobin. So in sickle cell we have this point mutation. In thalassemia there is not enough production of a particular chain, alpha or beta, right? Acquired genetic defects. Deficiency of phosphatidyl inositol linked glycoproteins. We see this acquired genetic defect in case of paroxysmal nocturnal hemoglobinuria. We will see each of these in detail. Antibody mediated destruction, in hemolytic disease of newborn, drug induced autoimmune disorders, all of these body starts attacking its own component. So it's antibody mediated destruction. Mechanical trauma. There could be microangiopathic hemolytic anemia, MAHA. Microangiopathic hemolytic anemia. It includes HUS, hemolytic uremic syndrome, disseminated intravascular coagulation, and thrombotic thrombocytopenia purpura. So MAHA includes HUS, DIC, and TTP. Cardiac trauma hemolysis, defective cardiac valves, repetitive physical trauma, bongo drumming, marathon running, karate chopping. Just some people who are fighters or in a martial art, they're consistently using their hand and blood can accumulate in that area. Infections of red cells, malaria, babesiosis, these are parasitic infections. Toxic or chemical injury, clostridial sepsis, snake venom, lead poisoning, membrane lipid abnormalities, A-beta lipoproteinemia, severe hepatocellular liver disease, sequestration, hypersplenism, and decreased red cell production. So we saw blood loss, we saw hemolysis where increased RBC destruction was there, now decreased red cell production. Now there is not even sufficient production to begin with. This can again be inherited. For example, defect leading to stem cell depletion, seen where in Fanconi's anemia and telomerase defects. Defect affecting erythroblastic maturation, thalassemia syndromes. Nutritional deficiency affecting DNA synthesis, B12 and folate deficiencies, and deficiency affecting hemoglobin synthesis, iron deficiency anemia. Erythropoietin deficiency leading to renal failure, anemia of chronic disease, immune mediated injury of progenitors, aplastic anemia can occur, pure red cell aplasia. Why? Obviously if progenitors are not being sufficient enough, there will be not enough or reduced, in some cases no RBCs. So pure red cell aplasia. Inflammation mediated iron sequestration, anemia of chronic diseases. Primary hemolytic neoplasms, acute leukemia, myelodysplasia, and myeloproliferative disorders, which will be in chapter 13 of the Robbins. Space occupying marrow lesions. Metastatic neoplasms, granulomatous disease, infections of the red cell progenitors, parvovirus, B19 infections, one of the most common causes of reduced RBC. In case parvovirus B19 infection, in case of an anemic person, usually normal person recovers quickly and there is not much problem, but in case of anemic person, it can lead to even a severe case of anemia, where they are already having anemia, it can lead to even severe anemia. Unknown mechanisms would include endocrine disorder, hepatocellular liver disorders, etc. Now, how will we assess RBCs? We know for diagnosis of anemia, we saw two factors. We check the hematocrit and we check the hemoglobin. But we want to assess RBCs that we have. Is it a good RBC? Okay, is it sufficient? Is it perfect? Is it not? Is normocytic, normochromic? There's no any problems with color or pallor or with increased 1/3 pallor. We want to make sure. So we see mean cell volume. What is that? Mean cell volume is the average volume of RBC in femtoliters. That's the measure. Mean cell volume is something we see. What is the normal MCV? Normal MCV we measure in mean cell volume. We will take this as 80 to 100 femtoliter. It is the average volume for RBC in femtoliter. Now, mean cell hemoglobin, MCH, mean cell hemoglobin. It is the average quantity of hemoglobin per RBC. For mean cell volume, we saw average volume of RBC in femtoliter. Now, for purpose of hemoglobin, we see average quantity of hemoglobin per RBC. It is seen in picogram. So, this is picogram, mean cell hemoglobin. It is 27 to 33 picogram. Right? MCH. And this is MCV, mean cell volume, mean cell hemoglobin. Now we see MCHC. This is mean cell hemoglobin concentration. It is the average concentration of hemoglobin given in a given volume of packed RBC. Now we saw per RBC in a given volume of packed RBC. Then that is gram per deciliter, gram per DL. What is it? 33 to 37, right? MCHC. This is 33 to 37. What? Gram per DL, right? And red cell distribution width, it is a coefficient of variation of red cell. Percentage, it's always in percentage form. Red cell distribution width 11.5 to 14.5. These are the things we look at, right? Now, severe anemia leads to diminished hemoglobin and oxygen content of the blood. If someone has an extreme anemia, there will be reduced hemoglobin and oxygen content in the blood, obviously. What are the common clinical features of the patient that comes with anemia? They are pale and they often report weakness, malaise, easy fatigability. They get tired very easily. Dyspnea, they have problem breathing. They are short of air. And then they have mild exertion. They work, they get tired easily. There's just constant state of tiredness. Hypoxia causes fatty changes in liver, myocardium and kidney. Myocardial infarction if CAD, that is coronary artery disease, is already present. Acute blood loss, shock, oliguria and anuria can develop due to renal hypoperfusion. Headache, dimness of vision and faintness in case of CNS. So, anemia is not something that should be taken lightly. Person will present with not such a major clinical feature until it gets severe. They will be pale and having weakness, tired, easy fatigability, dyspnea, mild exertion. But you need to realize that anemia is basically when the body is not getting sufficient oxygen, right? That is known as hypoxia. And hypoxia can affect almost all major organs. Liver, myocardium and kidney. It is liver, heart, muscle and the kidney. Now, in case of heart, MI can occur if already person is having CAD, coronary artery disease, and then they are anemic, then they can have MI. In case of person who already is a patient of chronic kidney disease or any problem with kidney, renal problem, acute blood loss, shock, oliguria and anuria can develop due to renal hypoperfusion. If your kidneys are getting sufficient blood, what can happen? Acute blood loss, shock, oliguria and anuria, right? And in case of CNS, the central nervous system is also such an important part of body. If it doesn't get enough oxygen, there can be headache, dimness of vision and faintness. Now we saw the first etiology for anemia was anemia of blood losses, where it was acute and chronic, right? Effects of blood loss are mainly due to the loss of intravascular volume. That is, in the blood vessel there is not sufficient volume, which can lead to cardiovascular collapse, shock and death, right? Cardiovascular collapse, shock and death. Now, clinical feature of a patient who presents with blood loss, anemia related to blood loss, what we have to look for? Rate of hemorrhage, whether bleeding is external and internal, very important. Bleeding is external, it can be detected quickly. Okay, this person is bleeding from this part. We can quickly give it treatment. But if bleeding is internal, it can take a while to detect, and it's often read or considered under chronic blood losses, right? A rate of hemorrhage, how quickly is the person bleeding? If patient survives, blood volume is rapidly, now if they have trauma and patient does happen to survive, the blood volume is rapidly restored by movement of water from interstitial compartment to intravascular compartment. Now suppose we're in interstitial spaces, interstitial tissues, the peritoneum area. Now body knows it's losing blood, and some major organs such as liver, myocardium and kidney need immediately oxygen supply. They cannot tolerate hyperperfusion for long periods of time, so they immediately need. So in that case, what happens is that blood volume, extra blood, whatever is present in the body, it moves from interstitial spaces into the intravascular, that is blood vessels, and this can lead to hemodilution and reduced hematocrit. This reduces tissue oxygenation. Now body has detected there is not sufficient RBC. What will happen? Erythropoietin is increased by kidney. The body knows there is not sufficient RBC to deal with this problem. The kidney is alerted and starts secreting increased erythropoietin, which is a precursor for erythroid series. Proliferation of erythroid precursor occurs and is colony forming unit E. CFU E increases because EPO increases. Why? Due to reduced tissue oxygenation. Body has detected there is not sufficient oxygen. And there is release of reticulocytes. What is reticulocytes? These are the precursors of RBC. They are just the primitive form in peripheral blood and takes about 5 days and they are released. The iron in hemoglobin is recaptured if RBC extravagate in tissues, not GIT or external bleeding. अगर क्या होता है तुम्हारे बॉडी में जो आयरन है, बॉडी कोशिश करते है उस आयरन को बचाए, इवन इफ दिस रिस्ट्रिक्शन ऑफ RBCs occurring anywhere, if it happens to be in tissue area, body tries to make sure that they can keep that iron, so they can be used, that iron can be used for further production of RBCs. Significant bleeding results in predictable changes in blood involving not only red cells but also WBCs and platelets. Now if there's increased bleeding, it's not just going to affect the RBC, it's going to also affect the other components of blood, which is WBC and platelets. So massive bleeding can lead to reduced BP can fall, compensated release of adrenergic hormones can occur, which mobilize the granulocytes. Now BP has fallen, right, due to massive bleeding. So body's like, okay, we need to fight back. So they fight back by increasing adrenergic hormones, which are all responsible for increasing BP, right? And mobilize granulocytes. So leukocytosis also occurs. Initially, RBCs are normocytic, normochromic, and there is increase in reticulocytes after 7 days, 10 to 15% they come. Now, when we do the peripheral blood smear, these reticulocytes will appear blue-red color. They won't appear completely red. They are really bluish, reddish, little blue dots in the cytoplasm due to presence of RNA. These reticulocytes aren't completely nucleic acid free. They still have RNA. Also, there will be increased in platelets. Platelets will also increase, just to try and clot and control the bleeding. So all three are affected. In chronic blood loss, what happens? It induces anemia only when the rate of loss exceeds the regeneration capacity of bone marrow or when iron reserves are depleted. So what happens? There could be slow pace of bleeding, right? But if your body is able to compensate that, then you won't even realize you're anemic because you're losing blood, but the body is able to compensate. In case of periods, women lose a lot of blood during menstruation, but there isn't a severe blood loss because body knows it will happen. So body has already prepared mechanism to fight off, so you won't experience any severe case of fatigability and paleness or dizziness because body is prepared for that thing. So these come under chronic blood losses. It is only detectable when your rate of regeneration of RBC is lower than rate of loss, which means you're losing blood more rapidly and your body is not able to compensate. So far we discussed about the definition of anemia, right? We talked about the diagnosing factors. We said we can diagnose anemia with the help of hemoglobin and hematocrit. We said they are both good methods, but in case of difference or in case of blood volume, changes in blood volume, these cannot be detected with hematocrit and hemoglobin. We said there are different ways to classify anemia. One is based on morphology, and based on morphology, there you can see RBC size, whether they are normocytic, RBCs are normocytic, microcytic, macrocytic, or upon the degree of hemoglobinization, whether they are normochromic and hypochromic. There is no such thing as hyperchromic. So RBCs can either be normochromic or hypochromic. We said microcytic hypochromic anemia, it is usually associated with hemoglobin disorders. Microcytic hypochromic. Now macrocytic anemias are due to abnormalities in maturation of erythroid in the bone marrow. We said we can classify anemia on base of etiology into three groups: anemia of blood losses, increased RBC destruction, which is hemolysis, or reduced RBC production. Blood losses could be acute or chronic. Increased RBC hemolysis, we can see there could be red membrane defect, RBC membrane defect, there could be enzyme deficiency, there could be hemoglobin abnormalities, there could be even acquired genetic defects as seen in paroxysmal nocturnal hemoglobinuria, and there could be antibody mediated destruction. Mechanical trauma can lead to MAHA, and cardiac trauma and repetitive physical trauma can all lead to hemolysis. There could be infections of RBCs in case of malaria and babesiosis. Now infection of red cell progenitor, we will see later on parvovirus that causes decreased RBC production. Increased destruction is seen in parasitic infection by malaria and babesiosis, right? Toxic or chemical injury, Clostridial snake worms, Clostridial sepsis, snake worms, and lead poisoning. These are toxic injuries. There could be abnormality in lipid play important role in cell membrane, right? And sequestration can happen, hypersplenism. Decreased red cell production. Why? When we have infection RBC progenitors with paro B19 infection, that's what I was talking about. Inherited genetic defects, Fanconi's anemia, telomerase defect, thalassemia syndrome. So there could be nutritional deficiencies. Body does not have sufficient vitamin B12 and folate deficiency. There could be erythropoietin deficiency. Why? Due to renal failure, leading to anemia of chronic diseases. Why? The kidney is not able to function properly. Hypoperfusion can occur. Space occupying marrow lesions can be there. Right? Now there are different ways to assess RBC. We said there was MCV, which is measured in femtoliter, which we said it was 80 to 100. We said it was MCH, mean cell hemoglobinization, which is measured in picogram, 27 to 33. And then we said we could measure it with MCHC, which is in gram per deciliter, 33 to 37. And red cell distribution with RCDW. 11.5 to 14.5. We said anemia can lead to hypoxia, and we talked about weakness, malaise, and how it affects heart, kidney, and liver, and even CNS. We talked about anemia of blood losses and effects of blood losses and how they play an important role, right? If patient survives, then we cannot detect anemia quickly because of our diagnosing factor being hemodilution and hematocrit. But in hemodilution, we'll see reduced hematocrit. And how does the body counteract blood loss? By increasing erythropoietin, CFUs increase, and reticulocytes increase in the blood. And in case of significant bleeding, it's not only the RBCs, WBCs can also leak out, right? So we have leukocytosis also, and there will be increase in platelet. Chronic blood loss is only detectable in case where your rate of blood loss is greater than the rate of RBC production. If they are balanced, then the body cannot easily detect it, right?